Welcome to Nurse's Lab. Today, we're diving into one of the most important updates in emergency care, the American Heart Association 2025 Basic Life Support Guidelines. If you're a nurse, paramedic, physician, medical student, or CPR instructor, these updates directly impact your practice. And if you're preparing for certification or renewal, this video will give you everything you need to stay ahead. We're going to break down the major changes, the clinical reasoning behind them, and how they affect real-world resuscitation. By the end of this video, you'll be fully prepared to apply the 2025 BLS standards with confidence. So grab your coffee, settle in, and let's get started. Without further delay, let's dive into our topic. In this video, first we're breaking down every major update in AHA 2025 updates related to adult BLS, the new updated algorithm for BLS and FBAO, the updated sequence of resuscitation, the refined metrics for high-quality CPR, the updated compression to ventilation ratios, the latest guidance on defibrillation during cardiac arrest, the new updates on adult FBAO, new considerations for cardiac arrest in patients with obesity, and the expanded section on alternative CPR techniques. This is the complete evidence-based guide to the 2025 AHA Adult BLS updates, and by the end of this session, you'll be ready to apply every change with confidence. Now let's move into adult BLS. While the core principles remain the same, the AHA has strengthened several recommendations. 1. High-quality CPR remains the foundation. Rate 100 to 120, depth 2 to 2.4 inches, full recoil, minimize interruptions. 2. Rescue breaths receive renewed emphasis. This is a major philosophical shift. The AHA now emphasizes ventilation more strongly in drowning, opioid overdose, respiratory failure, and asphyxial arrest. Why? Because these arrests are respiratory in origin, and oxygenation is the key determinant of survival. 3. Early AED use remains critical. Apply as soon as available, follow prompts, resume compressions immediately after shock. The message is clear. If anyone performs high-quality CPR plus early defibrillation with appropriate ventilation, that will lead to best outcomes of the patients. Now let's move into detailed steps of ACLS algorithm based on 2025 updates for healthcare professionals. Act now and save a life. Follow these steps to act upon when somebody is with cardiac arrest. Step 1. Assess the patient for response. How to assess or what to be observed during assessment? Here you go. You need to assess the following. 1. Check whether the patient is responding to rule out unresponsiveness of the patient by tapping the shoulder and shouting to him, "Are you okay?" 2. Check for breathing to rule out whether the patient has any life. 3. See whether the patient is breathing abnormally to figure out gasping. If this check says to your mind that the patient has no response, then move on to step 2. Activate emergency response. How to activate? Call to your local emergency helpline number or ambulance service and inform the situation and remind them to bring AED. After doing this, then step 3. Start CPR. How to do? Press hard and fast in the center of the chest. Once you do that and your help arrives to the scene, then you will move on to the next. Step 4. Apply the AED pads as follows. Place one pad on the right upper chest, just below the right collarbone, clavicle, and the other pad on the left side of the chest, just below the left nipple and along the mid-axillary line. Then follow AED prompts and resume CPR for 2 minutes. If suspected opioids overdose, give a dose of naloxone if available. Once done, next step is to continue CPR, so the cycle continues as shown in the algorithm. The 2025 AHA guidelines refine the sequence of resuscitation to make every second count. This updated sequence sharpens how we assess, how we act, and how we deliver life-saving interventions, emphasizing rapid recognition, immediate high-quality CPR, early ventilation for patients, and faster integration of defibrillation. First, let's see the recommendation regarding recognition of cardiac arrest. 1. If an adult is found unconscious or unresponsive and is not breathing normally, for example, only gasping, the lay rescuer should presume the individual is experiencing cardiac arrest. 2. If an adult is found to be unconscious or unresponsive and is not breathing normally, for example, only gasping, a healthcare professional should check for a pulse for no longer than 10 seconds. If a definite pulse cannot be detected within this time, cardiac arrest should be presumed and appropriate action taken. Now, let's see the recommendation for initiation of resuscitation. Updates in case of lay rescuer, untrained or trained. 1. All lay rescuers should perform chest compressions on adults who are suspected to be experiencing cardiac arrest. 2. If a lone responder finds an adult in cardiac arrest, they should first activate the emergency response system, then promptly start CPR, beginning with chest compressions. 3. If an adult experiences cardiac arrest and you are alone with a mobile phone, you should first activate the emergency response system and then promptly start CPR, beginning with chest compressions. 4. For lay rescuers trained in CPR, it is appropriate to administer rescue breaths along with chest compressions when assisting an adult experiencing cardiac arrest. 5. When personal protective equipment, PPE, is readily at hand, it is appropriate for rescuers to wear PPE while performing CPR on adults experiencing cardiac arrest. Updates in initiation of resuscitation by healthcare professional. 1. In the event of an adult cardiac arrest, a single healthcare provider should begin by performing chest compressions instead of starting with ventilation. 2. It is appropriate for healthcare professionals to administer chest compressions and provide ventilation to all adult cardiac patients experiencing cardiac or non-cardiac in nature. Next, let's see the recommendation regarding opening the airway in adults in cardiac arrest. 1. When caring for an unresponsive adult patient without suspected cervical spine injury, healthcare professionals and trained lay rescuers should open the airway using the head tilt, chin lift technique. 2. For adults with a known or suspected basal skull fracture or severe coagulopathy, it is advisable to use an oropharyngeal airway rather than a nasopharyngeal airway. 3. The insertion of an airway adjunct, such as an oropharyngeal or nasopharyngeal airway, can be appropriate for unconscious adult patients who lack unresponsiveness and lack a cough or gag reflex, as it aids in effective ventilation. 4. The regular application of cricoid pressure during adult cardiac arrest is not advised. What are the recommendations for opening the airway after head and neck trauma? 1. For adult patients with head and neck trauma, trained rescuers should open the airway by performing a jaw thrust maneuver without extending the head. 2. If an adult with head and neck trauma cannot have their airway opened using a jaw thrust and airway adjunct, trained rescuers should proceed to open the airway using the head tilt chin lift technique. 3. For adults experiencing head and neck trauma, lay rescuers are advised against using rigid cervical devices to restrict spinal movement, as improper application by those without training can potentially harm. Metrics for high-quality CPR. High-quality CPR is the single most powerful intervention in cardiac arrest, and the 2025 AHA guidelines sharpen the metrics that define it. In this section, we break down the updated standards for rate, depth, recoil, ventilation, and minimal interruptions, the measurable actions that turn CPR from a procedure into a life-saving science. First, let's discuss about positioning and location for CPR. 1. During adult cardiac arrest, rescuers are advised to carry out chest compressions with the patient's torso positioned at roughly the same height as the rescuer's knees whenever feasible. 2. When delivering chest compressions to an adult, position the heel of one hand in the center of the chest, specifically on the lower half to lower third of the sternum. Place the heel of your other hand directly on top of the first hand, overlapping them to ensure proper technique. 3. For adult cardiac arrest, resuscitation should typically take place at the location where the individual is discovered, provided that high-quality CPR can be delivered safely and effectively. 4. For adult cardiac arrest, CPR should be performed with the patient lying on their back, supine, on a firm surface, provided this can be done without causing any delay to starting chest compressions. 5. When performing chest compressions during adult cardiac arrest, rescuers may opt to position their dominant hand on the sternum. 6. For adult patients who suffer cardiac arrest while lying on prone, it is generally advisable to turn the patient onto their back before starting chest compressions. If turning the patient is not feasible or safe, rescuers may opt to perform CPR while the patient remains in the prone position.
Next, let's discuss about chest compression fraction and pauses. During adult cardiac arrest, it is important to minimize the duration of chest compression interruptions both before and after delivering a shock. When performing rhythm checks during adult cardiac arrest, healthcare professionals should limit pulse checks to no longer than 10 seconds. If a pulse is not clearly detected within this time, chest compressions must be resumed without delay. For adults experiencing cardiac arrest, it is appropriate to promptly restart chest compressions following shock delivery, instead of stopping CPR to check the rhythm after the shock. If there are 2 or more rescuers present during an adult cardiac arrest, it is advisable to alternate the person performing chest compressions roughly every 2 minutes, or after approximately 5 cycles of compressions and ventilations at a 30-to-2 ratio. For adults experiencing cardiac arrest who are undergoing CPR without an advanced airway, it is appropriate to briefly pause chest compressions to provide 2 ventilations, each lasting approximately 1 second. In cases of adult cardiac arrest, maintaining a chest compression fraction of at least 60% during CPR may be advisable. Beyond the advanced life support setting, where invasive monitoring is accessible, there is limited evidence regarding the effectiveness of conducting a pulse check during CPR in adult cardiac arrest cases. What is the recommendation for chest compression depth and rate? When performing manual CPR on an average adult, rescuers should compress the chest to a depth of at least 2 inches, 5 centimeters, but must be careful not to exceed a depth of 2.4 inches, 6 centimeters. In adult cardiac arrest scenarios, utilizing audio-visual feedback devices to provide real-time guidance is considered appropriate for optimizing CPR performance. For adult patients experiencing cardiac arrest, it is appropriate for rescuers to deliver chest compressions at a rate between 100 and 120 per minute. Allowing the chest wall to fully recoil between compressions by avoiding leaning on the chest can be advantageous for rescuers performing CPR on adults in cardiac arrest. When managing adult cardiac arrest, it may be advisable to deliver chest compressions, ensuring that the duration of compression and the time for chest recoil or relaxation are roughly the same.
Ventilation and compression to ventilation ratio. Ventilation is more than just adding breaths. It's a critical determinant of survival. In this section, we break down the updated ventilation standards and the compression to ventilation ratios that define high-quality BLS. Let's discuss about compression to ventilation ratio in adult cardiac arrest. 1. both lay rescuers and healthcare professionals are advised to perform CPR using cycles of 30 chest compressions followed by 2 rescue breaths until an advanced airway, such as a supraglottic airway or endotracheal tube, is placed. 2. For adults experiencing cardiac arrest who do not have an advanced airway in place, healthcare professionals may opt to perform continuous chest compressions while providing asynchronous ventilations. Defibrillation during adult cardiac arrest ratio. Defibrillation is the single most time-sensitive intervention in adult cardiac arrest, and the 2025 AHA guidelines sharpen exactly when and how it should be delivered. In this section, we break down the updated defibrillation sequence, pad placement considerations, and the critical timing that maximizes survival while keeping CPR interruptions to an absolute minimum. First, let's discuss about pads for defibrillation in adult cardiac arrest. 1. For adults experiencing a cardiac arrest, it is appropriate to apply defibrillation paddles or pads to the exposed chest in either the anterolateral or anteroposterior position. Additionally, using paddle or pad electrodes with a diameter greater than 8 centimeters is recommended. 2. When applying defibrillation pads to an adult in cardiac arrest, it may be appropriate to reposition the bra rather than taking it off entirely. Now let's see about CPR before defibrillation in adult cardiac arrest. 1. For adults experiencing cardiac arrest, it is advised to continue CPR until a defibrillator or AED becomes available and can be used. 2. In cases of adult cardiac arrest that are not witnessed, it is appropriate to deliver a short interval of CPR while a defibrillator is being located and prepared for operation. 3. For adults experiencing cardiac arrest, it is appropriate to deliver defibrillation without delay for witnessed or monitored VF or pulseless ventricular tachycardia when a defibrillator is already in place or can be used immediately. Adult foreign body airway obstruction. Foreign body airway obstruction remains one of the most rapidly fatal emergencies, and the 2025 AHA guidelines introduce a major shift in how we manage choking in adults. This updated algorithm prioritizes a safer, more effective sequence, starting with back blows and progressing to abdominal thrusts to clear the airway faster and reduce injury. In this section, we break down the new adult FBAO algorithm and the life-saving steps every rescuer must know. First, let's discuss about relief of FBAO in conscious adult patients. 1. For adults experiencing a severe foreign body airway obstruction, alternate between 5 back blows and 5 abdominal thrusts. Continue these cycles until the obstruction is cleared or the individual becomes unresponsive. 2. Rescuers must initiate the emergency response system when an adult experiences a severe foreign body airway obstruction. 3. For adults experiencing mild foreign body airway obstruction, allow them to attempt to clear the airway by coughing while closely monitoring for any indications of severe airway obstruction. Now let's discuss about relief of FBAO in unconscious adult patients. 1. If an adult with a severe foreign body airway obstruction becomes unresponsive, rescuers should initiate CPR, starting with chest compressions. Additionally, the emergency response system should be activated if it has not already been done. 2. When performing CPR on adults with a foreign body airway obstruction, rescuers should check for and remove any visible foreign object while opening the airway before attempting to deliver breaths. 3. Blind finger sweeps are not recommended for adults experiencing a foreign body airway obstruction, FBAO. Relief of FBAO in special circumstances. 1. If the rescuer cannot wrap their arms around the person's abdomen, they should perform repeated cycles of 5 back blows, slaps, followed by 5 chest thrusts for adults experiencing severe FBAO. Continue this process until the obstruction is cleared or the individual becomes unresponsive. 2. For adults in the advanced stages of pregnancy who are experiencing severe foreign body airway obstruction, FBAO, perform repeated cycles consisting of 5 back blows followed by 5 chest thrusts. Continue these cycles until the obstruction is cleared or the individual becomes unresponsive. 3. The effectiveness and safety of suction-based airway clearance devices in adults experiencing foreign body airway obstruction have not been determined. Current evidence is inadequate to support any recommendation regarding their use. In this next breakdown, let's see about cardiac arrest in adult patients with obesity. 1. CPR for adults with obesity experiencing cardiac arrest should be administered using the same methods as for adults without obesity. 2. For adults with obesity experiencing cardiac arrest, rescuers should take into account how transferring the patient to a firm surface might delay the start of chest compressions. 3. Rescuers may need to apply greater force during chest compressions to ensure sufficient depth when treating adult patients with obesity experiencing cardiac arrest. 4. For adults with obesity experiencing in-hospital cardiac arrest, IHCA, utilizing a partial backboard or CPR board does not offer any advantage compared to administering chest compressions directly on a hospital mattress. Finally, in Adult BLS in 2025 updates, we are going to break down alternative techniques for CPR in adult cardiac arrest. In cases of adult cardiac arrest, mechanical CPR devices can be considered when manual chest compressions are difficult to perform or pose risks to healthcare providers. It is essential that rescuers minimize any pauses in CPR while setting up or removing the device. 2. For single rescuers, performing compressions from over the head of the patient may be considered in adult cardiac arrest. 3. The efficacy of heel or foot compressions during adult cardiac arrest remains uncertain and is not thoroughly supported by current evidence. 4. The use of mechanical CPR devices in adult cardiac arrest should not be routinely recommended. The 2025 AHA guidelines bring important refinements to pediatric basic life support, sharpening how we assess, respond, and intervene when a child is in cardiac or respiratory arrest. These revised algorithms reflect the latest evidence in pediatric physiology, emphasizing early recognition, early ventilation, and rapid coordinated action. In this section, we break down the updated Pediatric BLS pathway, which enables every healthcare provider and lay rescuers from initial assessment to CPR, ventilation, and defibrillation, so every rescuer can deliver faster, safer, and more effective care when seconds matter most. First, we are going to discuss about pediatric chain of survival, then treatment of respiratory failure, then sequence of resuscitation, and last but not least, about management of shockable rhythms. Now let's discuss about pediatric chain of survival. The pediatric chain of survival recognizes that children don't arrest like adults. They deteriorate first. The 2025 AHA guidelines sharpen this chain to focus on prevention, early recognition of respiratory failure, rapid activation of help, and high-quality CPR with effective ventilation. In this section, we break down the updated pediatric survival pathway that guides rescuers from the first sign of distress to advanced care and recovery. This chain is designed to guide rescuers from the moment a child shows distress all the way through recovery. Now let's look at treatment of respiratory failure. Respiratory failure happens when breathing is insufficient, leading to poor oxygen and carbon dioxide exchange. Causes include issues with breathing control, airway obstructions, muscle failure, or lung disease. Life-saving interventions may involve assisted ventilation, clearing airway obstructions, and giving naloxone in opioid overdoses. So, what are the recommendations for opening the airway? 1. Unless there is a suspicion of cervical spine injury, open the airway in infants and children using the head tilt chin lift technique. 2. For infants and children with a suspected cervical spinal injury, open the airway using a jaw thrust maneuver without performing a head tilt. 3. If the jaw thrust fails to open the airway in infants and children with suspected cervical spinal injury, perform a head tilt chin lift maneuver. Next, see about the recommendations for treatment of inadequate breathing with a pulse. 1. If infants or children have a pulse but their breathing is absent or insufficient, it is necessary to provide assisted breaths. 2. For infants and children who have a pulse but show no or insufficient breathing effort, it is appropriate to provide 1 breath every 2 to 3 seconds, which equals 20 to 30 breaths per minute. Finally, let's see the recommendations for foreign body airway obstruction. 1. Infants or children experiencing mild foreign body airway obstruction should be encouraged to cough in order to clear the airway while closely monitoring them for any signs of progression to severe obstruction. 2. For infants experiencing severe foreign body airway obstruction, administer cycles of 5 back blows followed by 5 chest thrusts, and continue alternating these actions until the obstruction is cleared or the infant becomes unresponsive. 3. If a child is experiencing severe FBAO, you should alternate between giving 5 back blows and 5 abdominal thrusts, repeating these cycles until the obstruction is cleared or the child becomes unresponsive. 4. If an infant or child with a severe foreign body airway obstruction becomes unresponsive, rescuers should immediately begin CPR, starting with chest compressions, and should not check for a pulse. 5. When performing CPR on infants or children with a foreign body airway obstruction, rescuers should check for and remove any visible foreign object while opening the airway before attempting to deliver breaths. 6. The effectiveness and safety of suction-based airway clearance devices in infants and children remain unproven. Currently, there is not enough evidence to provide a recommendation for their use in this population. 7. Do not perform blind finger sweeps in infants and children with foreign body airway obstruction. Sequence of resuscitation. The 2025 AHA Pediatric BLS sequence follows a CAB structure: compression, airway, breathing, with pediatric-specific modifications emphasizing early ventilation, early recognition, and rapid AED use. This is the official sequence synthesized from the 2025 AHA Pediatric BLS Guideline Update and algorithm descriptions. Now let's see about the Pediatric Basic Life Support for ages 1 year to puberty for lay rescuers. This consists of 3 steps which you can see in this algorithm, and we are going to discuss in detail about each steps. Step 1. Get help immediately. If the child or infant does not respond, call out loudly for assistance. Dial emergency services, 911. Ask someone nearby to bring an AED. If the child or infant is not breathing normally, begin CPR right away. Step 2. Provide chest compressions and rescue breaths. Start CPR. For infants, use the heel of 1 hand. For children, use 2 hands. Push firmly and quickly in the middle of the chest. After 30 compressions, give 2 rescue breaths. Continue cycles of 30 compressions and 2 breaths until an AED is available or emergency personnel arrive. Step 3. Use the AED as soon as it is available. Power on the AED and carefully follow the voice instructions. Use pediatric or infant pads if available. If only adult pads are present, ensure they do not touch each other. Keep performing CPR with breaths until medical help takes over. Next, we are going to see the updates regarding the 2025 AHA Pediatric Basic Life Support for single rescuers and 2 or more rescuers, which is shown in this algorithm in details. First, let's discuss about initiation of CPR. 1. lay rescuers should start CPR right away if an infant or child is unresponsive, not breathing normally, and shows no signs of life. Checking for a pulse is not necessary. 2. For infants and children who show no signs of life, healthcare professionals may check for a pulse for up to 10 seconds. If a definite pulse is not detected, it is appropriate to start chest compressions. 3. Starting CPR with the sequence of compressions, airway, breathing, rather than airway, breathing, compressions may be appropriate. Next, let's see about components of high-quality CPR. 1. Infants and children experiencing cardiac arrest should receive conventional CPR, which includes both chest compressions and rescue breaths. 2. When performing CPR on infants and children experiencing cardiac arrest, it is important to keep interruptions to a minimum, ensuring that any pause in chest compressions does not exceed 10 seconds. 3. Rescuers must ensure that the chest fully returns to its original position after every compression. 4. If lay rescuers are either unable or choose not to give rescue breaths to an infant or child experiencing cardiac arrest, performing chest compressions alone is considered an acceptable alternative. 5. A chest compression rate of 100 to 120 per minute is appropriate for infants and children. 6. For infants and children, rescuers should perform chest compressions that depress the chest by at least 1/3 of its anterior-posterior diameter, about 1.5 inches, 4 centimeters, for infants, and 2 inches, 5 centimeters, for children. 7. Healthcare professionals should conduct a rhythm assessment every 2 minutes, ensuring the check does not exceed 10 seconds. 8. Administering ventilations with 100% oxygen during CPR is considered appropriate. 9. During CPR without an advanced airway, a single rescuer should use a chest-to-ventilation ratio of 30:2, while 2 rescuers should use a ratio of 15:2. Next, let's see about the techniques used for CPR. 1. For infants, rescuers should perform chest compressions using either the one-hand technique, placing the heel of one hand on the sternum, or the 2-thumb encircling hands technique. If it is not possible for the rescuer to encircle the infant's chest, the heel of one hand technique is recommended for chest compressions. 2. For children, it is appropriate to use either a one-hand or 2-hand technique when performing chest compressions. Now we'll see about the support surfaces to be used for CPR. 1. It is appropriate to carry out chest compressions on a firm surface when resuscitating infants and children. 2. When performing IHCA, the use of a backboard is considered appropriate to enhance the depth of chest compressions in infants and children. Next, management of shockable rhythms. When a cardiac arrest presents with a shockable rhythm, every second becomes a race against time. The 2025 AHA guidelines sharpen the strategy for managing ventricular fibrillation and pulseless ventricular tachycardia, emphasizing rapid defibrillation, uninterrupted high-quality CPR, and precise timing of interventions. In this section, we break down the updated approach to recognizing and treating shockable rhythms, the pathway with the highest potential for survival when executed flawlessly. First, let's discuss about coordination of shock and CPR. 1. For infants and children, continue performing CPR until an AED or manual defibrillator is prepared to administer a shock. 2. For infants and children experiencing VF or PVT, it is advised to deliver a single defibrillation shock promptly, then begin CPR immediately with chest compressions. Efforts should be made to reduce peri-shock pauses as much as possible during CPR for infants and children. Next, we will see about type of defibrillator. 1. For infants and children under 8 years old, it is advised to use a pediatric attenuator when operating an AED. 2. For infants and children being treated by a qualified healthcare professional, the use of a manual defibrillator is appropriate when a shockable rhythm is detected. 3. If a manual defibrillator or an AED with a pediatric attenuator is not accessible, It may be acceptable to use an AED without a pediatric attenuator for infants and children. Next, let's see about defibrillator paddles and pads, size, type, and position. 1. For infants and children, it is advised to use the largest paddles or self-adhesive pads that can comfortably fit on the chest, ensuring there is adequate space between them. 2. When applying self-adhering pads to infants and children, it is acceptable to use either the antero-posterior or antero-lateral position. 3. When providing electric current for defibrillation in infants and children, both paddles and self-adhesive pads can be regarded as equally effective and efficient options.
Critical knowledge gaps due to insufficient pediatric data. Understanding pediatric resuscitation and emergency response is crucial for healthcare professionals, caregivers, and anyone involved in childcare. This guide addresses common and important questions regarding effective techniques for defibrillation, chest compressions, and airway management in children which doesn't have adequate evidences. By exploring evidence-based practices and the reasoning behind them, we aim to provide clear, practical information that supports safe and effective interventions during pediatric emergencies. How often should you check the heart rhythm during CPR? What is the best breathing rate during CPR for people with or without a breathing tube? Does age change this rate? What is the best speed for chest compressions during CPR? Does the best speed change with age? What is the best chest compression fraction, CCF, for children to get the best results? What is the best way to stand or position yourself when doing chest compressions? Should you use a step stool, kneel on the bed, or stand? What happens if you press on the chest and don't let it fully rise between compressions? What is the best amount of oxygen to give during CPR? What is the best ratio of chest compressions to breaths? When should you give shocks for VF or pulseless VT, and how much should you give? What tools can help decide when to stop CPR for children both inside the hospital and outside the hospital? How long should CPR be done before giving a shock? How long is a long pause in chest compressions? What is the shortest pause you should aim for? Is giving one shock as good as giving several shocks in a row for children? What could go wrong if you shock a heart rhythm that shouldn't be shocked with a manual defibrillator in the hospital? Is it faster to shock with sticky pads than with paddles? Where should pads be placed for defibrillation in children? Should they go front to back or front to side? What is the best chest compression fraction for better outcomes in child CPR? Which works better for choking in children, chest compressions or pushing on the belly? Are commercial devices safe and effective for treating choking? Should mechanical devices be used for chest compressions in children? How can bedside ultrasound help check the heart rhythm and pulse? What is the best way to check if breaths are working during rescue breathing and CPR? Unfortunately, for all, infant CPR has one of the most important technique changes in the 2025 update. Most of them are covered in the Pediatric BLS. This is only for healthcare personnel who want the information to be customized for infants alone. 1. Single rescuer compression technique. New updates. 1. 2 thumb encircling hands technique. 2. Heel of one hand on the sternum. Old, 2 finger techniques and encircling thumbs for 2 rescuers only. Why the change? 2 finger technique is ineffective at achieving proper depth, reduces fatigue, and allows quicker transition between compressions and breaths. Let's see about further clarity on the same. If it is a child of 1 year to puberty, 1 hand or 2 hands, depending on the child's size, use what achieves correct depth with full recoil. In case of infant, less than 1 year,
2-thumb encircling or heel of one hand, no more 2-finger technique. 2. AED use in infants. The AHA now encourages earlier AED use even in infants under 1 year because modern AEDs deliver safer, more controlled energy. Pediatric attenuators are widely available, and delaying defibrillation reduces survival. 3. Airway and breathing. 30-2 for single rescuer, 15-2 for 2 rescuers, gentle breaths just enough to see chest rise. 2025 AHA revised updates on opioid emergency response. With opioid-related arrests increasing globally, the AHA expanded its guidance. Key updates. Naloxone administration is now more explicitly integrated into BLS. Emphasis on ventilation first, not naloxone first. If the patient is not breathing, start CPR. Naloxone should not delay CPR or AED use. Let's recap the biggest changes. Back blows added to adult and child choking protocol. 2-thumb encircling or heel of one hand, no more 2-finger technique. Pediatric compression depth capped at 2.4 inches. Greater emphasis on rescue breaths in non-cardiac arrests. Earlier AED use in infants. Expanded opioid response guidance. These updates reflect the latest evidence and aim to improve survival across all age groups. Thanks for watching. If you found this breakdown helpful, hit like, subscribe, and share it with your colleagues. And if you want to prepare for BLS certification examination, kindly visit our website, www.nurseslab.org. We have well-structured practice tests which is available for free to use. Or if you want a short series on each update, let me know. I'd be happy to create it. Stay safe, stay informed, and I'll see you in the next video.